Good afternoon, viewers. Welcome once again from Sunetra Family Eye Care Center. Myself, Dr. Amitava Biswas, to you today with the 43rd episode of our patient education series, which is a lockdown byproduct that we started 43 weeks ago. Today, we have with us an expert on pediatric infectious diseases who has been in this program earlier too, Dr. Professor Valsan Philip Verghese. I'll come to his introduction a little later. I'd like to talk about the topic first. You say a few weeks ago, one of my Facebook friends posted a public notice addressed to the Chief Minister, requesting the Chief Minister to arrange for additional beds and ICUs for children in preparation for the third wave of the pandemic. Now, it just so happens, that there is a talk about the third wave, and there is a fear among the general public that perhaps children are going to be affected more. We will definitely learn about all this from our expert. For the time being now, with Dr. Valsan's permission, I'll probably show a slide of introduction about Dr. Valsan. So that is it. Dr. Valsan Philip Verghese and I were fortunate enough, particularly me, to have been classmates at medical school, that is Christian Medical College, Vellore. Dr. Valsan never left after graduation, never left the alma mater. Subsequently, he did his diploma in child health and the master's degree in child health from our alma mater. He moved on to Canada to do a fellowship in pediatric infectious diseases, an ADVAC fellowship in vaccinology from Geneva, a Green Family Foundation fellowship in infectious diseases and immunology from Miami, USA. And presently, he is professor of Pediatric Infectious Diseases at the hospital, Christian Medical College and Hospital, Vellore. He is also an additional deputy chair of Hospital Infection Control Committee. He is faculty of Clinical Epidemiology Unit, and he has been a researcher on vaccine trials, vaccine preventable disease surveillance, and biomarker studies. With these words, I'll probably hand over the mic to Dr. Valsan and welcome him once again heartily to this program of ours. Dr. Valsan, welcome.
Thank you, Dr. Biswas. Thank you for having me here once again. It's always a pleasure to be with you and to interact with your viewers.
Okay, great. So we are going to talk today about the children and the pandemic, right?
Yes.
Yeah. So would you like to take off on the topic and say something,
Sure.
or would you like me to ask some questions to you? How would you like to go about it?
I'm happy for you to ask me the questions because I find, that sort of gets the creative juices flowing.
Well, in my introduction, I did mention about the concern about many people over social media that I noticed that the third wave, if at all it's there, it's going to affect the children more. What is your view on this? I mean, do you think there is going to be a third wave at all to begin with?
So I'm going to talk a little bit on this because as all my classmates and Dr. Amitava know, I love to talk with good company. So the thing is, I think we have been hearing a lot about this third wave, and we've been hearing it from a lot of experts in the country that there is a third wave going to happen. Because the first wave affected predominantly older people, and this time a lot of young people are affected coming to hospital. So people are worried that the third wave will affect, shall we say, one generation younger when it comes around. Now, question number one, will there be a third wave? Answer to that is the second wave itself we were not expecting. Although a lot of people in hindsight have been saying, oh, we always told you to be prepared, but I don't think anyone expected the magnitude of the second wave.
To our viewers, I just would like to say that there seems to be a technical glitch on the side of Dr. Valsan Philip Verghese, probably a network connection error. He'll be back soon.
Yeah,
Yes.
no, I'm back. I'm back. So I don't
Yes.
think anyone expected the magnitude of the second wave that we have just seen. And the answer to that now, why did we have a second wave, is we have variants from the original wave.
So it seems there is a network issue at Dr. Valsan's end. Uh, Not a problem. I'm sure Dr. Valsan will sort it out very soon. Uh, we are going to, in the meantime, we will discuss a few of the issues that Dr. Valsan was supposed to talk about. So this is a slide set that was prepared by Dr. Valsan Philip Verghese on children and the pandemic. So a common question asked by many parents is that my child has fever. How do I know whether it is COVID infection? Well, the fact is, it is not easy to diagnose COVID apart from any other common viral illnesses, even for a doctor, because common symptoms such as fever and cough can be seen with other viral infections as well. However, if someone else in the household has been diagnosed with COVID, then it is likely that a child with fever and cough is likely to be having COVID as well. Another common concern for parents is what are the symptoms of COVID? Uh, well, majority of children with COVID infection may be asymptomatic or mildly symptomatic. The common symptoms include fever, cough, breathlessness or shortness of breath, fatigue, myalgia. Myalgia is actually pain of the muscles of the body. Rhinorrhea, that's a runny nose. Sore throat, a pain of the throat. Diarrhea, loss of smell, loss of taste, etc. You see, as you can notice, when we had the first wave, the primary symptoms were fever, cough, loss of smell, and loss of taste. And later on, in the second wave, we noticed that they were not necessarily the primary features. A lot of patients nowadays present with, say, fatigue, myalgia, even just a feeling of not feeling well could be leading on to COVID, a runny nose, even diarrhea. So these are the symptoms of COVID that one should keep in mind. Parents often like to know that when should I get my child tested for COVID? Well, If there are family members who are positive, then a child must also get tested. If the child has symptoms, of course, you must get the child tested. And if a child has only fever and the fever has continued beyond 3 days, then of course the child must go through an RT-PCR test for COVID. Another common question following that is that parents ask that my child's COVID test is positive, so what should I do? Well, as we mentioned earlier, there could be asymptomatic cases and there could be cases with mild symptoms. Asymptomatic children are usually identified while screening if family members are identified. They require monitoring for development of symptoms and subsequent treatment according to assessed severity. Then children with mild disease may present with sore throat, a runny nose, cough with no breathing difficulty. Few children may have diarrhea and other gastrointestinal symptoms. And these children may not need any special investigations. These children can be managed at home with home isolation and just symptomatic treatment. So the question that follows is, what is symptomatic treatment? For fever, simple paracetamol at the recommended dosage of 10 to 15 milligram per kg per dose can be repeated maximum every 6 hours, but maximum every 4 hours, but once in 6 hours or once in 8 hours should be good. Now, when should one give paracetamol? If the fever is significant enough, maybe 100, 101 or above. Symptomatic treatment for cough could be throat-soothing agents like warm saline gargles in older children only and adolescent. For children who are younger than that, may not be able to do gargle with warm saline. Ensure oral feeds in adequate amounts to maintain hydration of the body and a good, balanced, nutritious diet. Does the child need antibiotics? No. As a general rule, not indicated. What about all the medicines we are always hearing about? The medicines such as hydroxychloroquine, favipiravir, ivermectin, other antiviral agents, immunomodulators, including tocilizumab, interferon, B1A, convalescent plasma infusion, or even dexamethasone, which is a steroid. Well, there is no role of these drugs in mild and asymptomatic cases at all, not only for children, even for adults. So parents might like to know, what can I do to ensure that my child is okay? Well, maintain a monitoring chart, including counting of respiratory rate 2 to 3 times a day. When the child is lying down, you put a palm of the hand over the abdomen and count the number of times the abdomen goes up and down in a minute by breathing, normal breathing. Look for indrawing of the chest, which is an early sign of respiratory difficulty. Look for bluish discoloration of the body, cold extremities. Extremities means the hand and feet. Look out for inadequate urine output. Look out for oxygen saturation by a pulse oximeter or on a finger. If it goes down 94 or below that, one should be careful. Maintain a chart for adequate fluid intake. Maintain a chart for overall activity level of the child, especially for young children. The parents or the caregivers must contact the doctor in case any of these things are not okay. At this moment, I would like to take a short break because Dr. Valsan Philip Verghese is back in action. And over to him. Dr. Valsan, I was going through the slides in the meantime, and I
Good.
was talking about. So please pick up from
Sorry.
where I left.
I think the moral of the story is I should not talk too much.
Come on.
Yeah.
Yes, we were talking
So
about the third wave and
the
which
third
is
wave, yeah. So what we were saying is, uh, whether there will be a third wave. Someone was saying only, you'd need an astrologer to tell us, because what has driven the second wave is a more transmissible variant. Whether you're going to have more of these transmissible variants coming in, we don't know. We know the numbers have gone up, but one thing that's evident from the data that we have is that severity in children has not been affected. And the reason that children are not more severely affected is because the virus itself does not have enough of the receptors that it attaches to in the adults to cause severe disease in children. So, although the numbers have gone up in the second wave and may go up or be the same or less if there is a third wave, we would probably still say severity in children is not going to be more. And having said that, we also know that we've not actually had uh, much more admissions of children this year compared to the previous year. Neither have we had a lot more of ICU admissions. Sure.
great. So, then about children, there are so many FAQs or frequently asked questions,
Sure.
which I had communicated to you earlier, and you have been very kind to put them in a slide set. I mean, if you wish to go to that, then if I have the freedom to share there, then I can share it and you can talk about it.
Sure. You can just start off from where you stopped.
Uh-huh. Okay.
Yeah.
So I'll just run through the slide set from the beginning for your.
Sure.
This is your title slide, and this was the first slide which I read out to the viewers. If you want to add anything over what is written in the slide, you can say. Would you like to say anything?
Not really. I mean, we all know, I mean, all of us have children at home with cough, cold, fever. And normally we don't even, the experienced parent will probably not even go to the doctor till about 2 or 3 days is over. And that pretty much is the way coronavirus presents. And the only way to say this could be COVID is if someone in the family has had COVID. So, but otherwise, you can't differentiate clinically. So, sure.
The next slide was about symptoms of COVID, and
Right.
your
Yeah.
slide.
So,
Why did it become minimized? uh, oh, okay, fine. Yeah.
yeah. So, I think fever and cough are seen in about half of children. Older children, that is your adolescents, are the ones like adults who complain with fatigue and myalgia. Only a
Yeah.
minimum, only a few, less than 20% of children actually present with, the classic nasal discharge. So that's one of the things that may be useful. Most colds, you have rhinorrhea or nasal discharge. This is a little uncommon with COVID. And sometimes you can have fever and diarrhea with COVID, which is again, very non-specific. Older
Okay.
children can also have this loss of smell, loss of taste. that you see in adults. But again, to make a diagnosis in the first 3 days is difficult. And to be very frank, if your child just has fever, a lot of children get better in this stage and don't even progress on to moderate disease. About half of children will sit in the mild phase and then get better. So it's good to know the symptoms. You probably don't need to worry too much. You don't need to rush to hospital in the first 3 days, provided the child is drinking, eating well, the fever's coming down with antipyretics, and there is no other symptomatology that worries you.
Okay, great. Shall I go on to the next slide now?
Yes, please. So this was the one of the points you're making. If the child's fever is not subsided by day 4, that would probably be the only time to get tested. And again, you're high. You're more likely to consider COVID if someone else in the family has been positive. So if someone else in the family is positive, child does not have symptoms, don't test. If someone in the family is not positive, almost definitely don't test. But if someone's positive, fever's persisting, you reach day 4, probably that's the time to get tested in a local testing center, so that you are in the system, and people, you have someone to reach out to. A lot of places nowadays, you have fever clinics where if you're positive, they will follow you up. They have social workers, there are doctors whom you can call. So I think it's good to be in the system if you're beyond 3 days of fever and your child is symptomatic. Sure. Next slide. So yeah, this is just more of the same. So and a lot of children are asymptomatic. They don't even have symptoms. They only identified because the family got tested and the government said, let's test everybody. So if they are asymptomatic, all we are looking for is the child developing symptoms such as fever or cough, and there is no other investigations that need to be done. I know in adults sometimes you end up with these COVID packages, and to be very frank, a child who is mild symptoms or asymptomatic does not need to have any test done, and all you need is symptomatic treatment. Next slide. Yeah, so paracetamol is, for fever, standard dose 10 mg per kg. So a 10 kg child will be getting 100 or 150. 5 ml of syrup now comes as two strengths, 125 and 250. So you have to be, that's the one thing I would ask people to do. When you have a bottle of syrup, look at the strength. If it's a 5 ml 125, then a 10 kg child can have 5 ml. But if it's a 250, then a 10 kg child should have only 2.5 ml. It's an easy dose to remember, 10 milligram per kg per dose, and you can give it 3, 4, 5 times a day. For cough usually one of the things that we say is anything warm water, honey, any cough suppressant that, cough syrups that you are used to getting your child take. And then make sure that the child is adequately taking fluids and food. Again, this question comes, should I give an antibiotic? The answer is no. Like every other viral upper respiratory infection, antibiotics are not going to diminish or change the course of coronavirus infection, which in more than 50% of children don't even progress on to the moderate stage. Next slide. So yeah, this is, I think, one of the questions we always hear. Hydroxychloroquine was in the news. I think most people have stopped doing that. Adults, there was this recommendation to use favipiravir for mild cases. The government of India has, as of this month, removed that from the guidelines. There's no evidence that favipiravir actually makes a difference to whether you progress on to moderate or severe disease. Ivermectin, and a lot of governments were still giving ivermectin as part of their kit. Again, for children and even for adults, ivermectin has also been withdrawn. Then there's lopinavir ritonavir, which is actually a protease inhibitor. Remdesivir has been also much in the news. I've had my own colleagues practicing in Maharashtra saying that they have been giving remdesivir not for mild but for moderate infection to children admitted in hospital. To be very frank, there are no studies in children showing any benefit of remdesivir, and even in adults, there's a very small window for remdesivir, which actually is just before when the oxygen saturation requirement suddenly goes up, and before someone goes on to high flow oxygen or ventilation. And it's interesting that they have not even found a benefit in someone who's got critical disease on a ventilator. So there's no evidence in children. So, even remdesivir has been removed from the protocols. Immunomodulators you will hear about, that is used in sometimes in severe disease for very specific indications, not indicated in mild disease. And the other one is steroids or dexamethasone. Dexamethasone is used if you have moderate or severe disease with a low oxygen saturation. There is no role for using over-the-counter steroids or anything else, going to the pharmacy and saying, let me have a bit of dexamethasone, maybe it will help. There's no evidence it helps in those who are not severe enough and who don't need oxygen. Convalescent plasma has been tried in adults. Our own ICMR has tried it and found it to be not of benefit. So it's very interesting that a lot of these were repurposed drugs, that were drugs used for other indications. People tried it thinking, okay, maybe this might make a difference, but except for dexamethasone in severe cases, none of these drugs are being used at present.
Correct.
So this monitoring, I think this is the point at which you are talking about. And what I wanted to focus on is basically our respiratory rate monitoring. And this is something very interestingly, Dr. Biswas will remember. These respiratory rates were derived from CMC Vellore by someone who taught us pediatrics, Dr. Thomas Cherian. So he actually picked on respiratory rates that were predictive of whether a child needed to get into hospital or not. And this has been used by the WHO in the primary care setting to train non-medical people. So all you do is you have a watch and you look at the child's chest and you count the child's respirations. You don't need a stethoscope. It's actually easy to do. So I think the next slide I'm going to talk about that. Plus, I think everyone nowadays has a pulse oximeter at home. So that is one of the things that people do use to monitor whether you need to get into hospital. And then you look to see whether your child is active, whether he is taking orally. Next slide. Yeah, so this is where we are at a point where we probably need to get admitted. So this is the point at which a child progresses from mild to moderate disease. So symptomatology at home. Remember, we went to hospital on day 4 of the fever. Doctor said, wait for 48 hours. It's day 5. It's getting over. Fever is not come down. Child is, so that's one reason to go back to hospital. Second reason would be child is not taking food like he usually used to take and is lethargic, tired, lying down in bed. Your pulse oximeter saturation, which was 97, 98, 96, is now falling below 95. And even before the pulse oximeter falls, and remember, don't rely just on the machines, it's good if you can count your child's respiratory rate. So how does one remember these numbers? I probably think of it this way. A normal pulse rate is around 80 per minute. A respiratory rate is a quarter of that. 80 divided by 4, 20. So for all of us, an upper limit of normal respiration would be around 20. For children older than 5, you go down to 30. For children 1 to 5 years, you go down to 40. And for children less than 1 year, 50 if they are 2 to 12 months old, or 60 if they are less than 2 months old. These are the numbers. From 20, we are counting down. As you get younger and younger, If the respiratory rate is this or greater than this, that is the point at which you need to consider going to hospital. So at this point, whether if the respiratory rate has gone up, even if the saturation is good, fevers persisting with this
Yeah, it seems Dr. Valsan's network connection today in Vellore is erratic. Uh, well, we can't. It's beyond our human control. So the point that Dr. Valsan was trying to mention is that the younger the child's age, the faster child breathes, like more number of times. So you do that correction, and adult breathes about 20 times a minute. That's the upper limit. And for a child who is very young, say less than 2 months, when the respiration goes to more than 60 per minute, that is considered rapid respiration. And accordingly, according to age, he has shown this. It's there in the slide as well. We'll go on to the next slide, where the parent's concern is what will happen to my child after admission. Now, about investigations in the hospital, as a general rule, no lab tests are required routinely unless they are indicated because of associated comorbid conditions in that child. So, only if there are other associated diseases which can add to the sickness or the illness of the patient will the child might need some investigation. As far as treatment is concerned, the child is to be admitted in dedicated COVID healthcare center or a secondary level healthcare facility and monitored for clinical progress. And the mainstay of the course of the treatment for such a child who is admitted would be three things. That's one is to maintain fluid and electrolyte balance, encourage oral feeds, excepting in infants who are in the breastfeeding stage, for them it will be breastfeeds. And if oral intake is poor, intravenous fluid therapy should be initiated in the child, only if the oral intake is poor. Another concern will be after admission, what will happen to my child? For fever, as mentioned earlier, paracetamol at the dosage rate of 10 to 15 milligrams per kg per dose may be repeated 4 to 5 times a day, only if the temperature is more than 100.4 degrees Fahrenheit or more than 38 degrees centigrade. If there is a secondary bacterial infection or there is at least a suspicion, a strong evidence or evidence of a bacterial infection, then amoxicillin syrup may be added. And if the oxygen saturation falls below 94%, oxygen supplementation is to be initiated. Corticosteroids have a role in moderate and severe stage of the disease, definitely not in the early and asymptomatic stages. Corticosteroids may be administered in rapidly progressive disease, if at all, not required in all children with moderate illness, especially during the first few days of illness. Well, for our viewers, our guest speaker, Dr. Valsan, is back, and we will admit him back to the stream. And he is still in a
Hi.
Hey, Dr. Valsan, you're playing hide and seek.
I'm sorry. Okay, sure. Yeah.
So
So where
I
did you
had
reach?
run through. This is you were on this slide
Yeah.
when we left.
Yeah. Yeah.
Yes,
So basically, what I was trying to say is the respiratory rate is probably the best indicator as to when you should be what do you call it taking someone to hospital. Next slide. Yeah, so here again, where do you get admitted? So if a child is moderately ill, will get admitted into a secondary level healthcare facility where they pretty much do the same things that you did at home. That is, encourage oral feeds, give IV fluids if the child is not feeding well. Next slide. Yeah, continue the paracetamol. At this point, an antibiotic will be started if there is evidence of bacterial infection. Most people end up doing an X-ray to look for that at this stage. And oxygen is started if the saturation is below 94. So, like we said, only if the saturation is not being maintained, steroids are given at this stage. Next slide. So actually 97% of children do not progress beyond the moderate stage. So which is actually very reassuring, and that has been the same throughout, whether it is the first wave or the second wave. The risk of developing severe diseases less than 3%. Next slide. So this is just to emphasize what I was saying. If you look at the severe and critical disease, the children are the middle column, 2.5 plus zero point 0.4, that's 2.9% compared to 17-18% of adults. So which means 97% of children don't go into the severe or critical stage. Next
this
slide.
is the
Yes. So I think this is just a graphic to show that children tend to have a viral initial stage and then they recover without going into a progressive or a hyperinflammatory stage, which is seen in young adults, or the late fibrotic stage seen in older adults. Next slide. Yeah, so this is actually to answer the very first question you asked me. The numbers were more definitely in the second wave, and so those numbers that I'm showing you are all ages, not just children. We literally saw in 3 months in velocity the number of cases that were seen throughout the previous year. But like I told you, we did not see worse infections or more ICU admissions. And then Maharashtra, where we literally have seen the pandemic, explode. They actually gave us this data. That is, both if you compare last year and you compare this year, the proportion of pediatric infections was still less than 10%. And then the next one which they looked at was the case fatality rate. The case fatality rate is if a child has infection, what is the risk that that child can have a poor, bad outcome, such as death? And that was 0.07% or 7 in 1000. And that did not change again in the second wave. This was actually followed by data from Puducherry, which said no deaths were seen in children 0 to 5 years. And they counted, this is not the case fatality, this is they looked at the number of deaths to see how many were in children. 99% of deaths occurred in older people. Only 1% of deaths were in the 6 to 18-year age group. So, next slide. Yeah, so I think this is one of the questions that you did ask me about prevention. So I
yes.
just want to walk my way through that. The same principles that we spoke about with regards to staying safe, acting responsible, apply to children. It's not too early to teach them how to hand wash, soap and water, or hand sanitizer if you're going out. One of the mistakes I think a lot of us make, and I think that is, especially at the time when cases were coming down, was we were taking children out into crowded environments. And as that is one thing that we need to avoid as much as possible. Keep them distanced away from other people who are coughing or sneezing. That is, even if someone who's coming home, then children themselves can cough and sneeze, and although the amount of virus they produce is less, one does need to teach them how to cover the nose and the mouth, either with a tissue or with the elbow like this if they have to cough or sneeze. Now, one of the issues that we have all faced with children at home is the amount of screen time and social media usage. Screen time has literally gone up, more than doubled during the pandemic. Now, how do you reduce that, especially if you are working during the day, and you have, many children at home, one caregiver, is firstly to involve them in home activities, and it can be anything. This is actually a good time. I've heard a lot of parents say, this is a time that has enabled me to connect with my children. As simple as teaching them how to wash dishes, make food, help in the garden, make all this a shared activity. And that is something that we've always emphasized even before the pandemic, and now you are forced to do it because you don't have the option of sending them off to school. The last one is masking, and we spoke about that in one of our previous sessions. Children
Yes.
as young as 2 years can be taught to mask, and as I mentioned once, uh, they don't find it a chore. Uh, in fact, they enjoy wearing colored masks, masks with messages on them. And so that is one of the things that if we have to go out, even, for a walk into the garden, or if you, have to take them somewhere for immunization, if you have to take them to hospital, that is something that needs to be remembered. Masking, I think we did talk about knotting and tucking masks. And so that's in the next slide. And the last bit was about vaccinating parents. And I know you have some questions to ask me about vaccinating parents. We'll talk about it after the next slide. Next slide.
Yeah, there are 2 points here, Dr. Valsan.
Yeah,
If
sure.
you allow me, I'd like to just add a
Yes, please.
comment.
Yeah.
The point number two, keeping children away from crowded social environments.
Hmm.
Yeah, it's my personal feeling that once this so-called lockdown or the restricted lifestyle is lifted away, I'm
Hmm.
sure people are going to do the same mistake all over again. Again, start taking children out for all kind of parties and shopping malls. So let's see if people have become mature. And point number four is the reduction of screen time and social media. Well, there is a handicap that children have nowadays because all classes are going on online, so they do have
True,
to.
true. Yeah.
Yes, I know. Okay, let's go on to the next slide.
So I just wanted to point out that the increase in social screen time over and above school time has also become more,
I
and you
know.
can imagine. Yeah. So I think, we used to tell children, we used to tell parents, restrict the time you are on screen. So I would say follow the same principles, restrict the time other than school time. School time we have no control over. Even for classes, we are ending up using, modalities like this. So I don't think we have an option here.
Correct.
This I just put it up because this is useful. You get a lot of surgical masks. This can even be done with cloth mask for children because these are loose and you need a tight fit. That picture actually shows you make your knot at the point where the loop close to the ear. So you make a knot, yank it, put it close to the ear, and that actually tightens your mask. And let me see if I can, time permitting. So, so this
This
is
is
a surgical mask here. So what you're doing is your first knot is being made close to where the ear is here. So what this does, it actually One, it decreases your the length of uh, stuff that's going around the ear. The second thing it does, I'm not sure I'm showing it well. Let me see. It actually folds your mask so that you actually have an area which can be tucked inside when you
Mm.
finally wear it. So the first knot is close to where the mask itself is, and away from the other end of the earpiece. Sorry, yeah. So the knot is here, and then by tying the knot, you're actually folding the mask so that you actually can make it into a more easily fittable mask. So this is something you can even do with cloth masks. So I
This is
know you had some questions about vaccination, so I'm happy to answer those.
this tucking of the mask is particularly useful for small children who may not have a proper sized small sized mask with them, and it can
Absolutely,
make
yeah,
it tight
and you
fitting.
can.
Yeah,
I know.
good. So we'll go on to the next slide now.
Sure.
Yeah, so the vaccine question says, you see, the commonest question that is doing the rounds and with people I know is, can a breastfeeding mother take the vaccine?
Sure. So, yeah, so I pulled out this data, and I think as of this month, lactating mothers have been allowed to take the vaccine, and this is data that comes from the US, where this is just 2 out of 5 subjects in the US. These are people who received the Pfizer vaccine, and they looked at those lines with the dots are basically antibody levels, and they looked at that from day 21, which is actually the day after the second dose of vaccine was given, and they found that even with the first dose of vaccine, these mothers had antibodies, and yeah, and these antibodies persisted for nearly 80 days. And I think most experienced parents will know that young infants tend to have very little infection in the first 3 months of life, and that is basically because of mother's antibodies or maternal antibodies, which are naturally transmitted at delivery and through the breast milk. And this one study was again followed by another study in Israel with 84 breastfeeding mothers who had 2 doses, and they had 97% of them had actual neutralizing antibodies, which means these are antibodies that will neutralize the virus if the child is exposed. So you have, and shall we say, without vaccinating the child, you already have probably significant protection to your newborn infant by vaccinating a lactating mother. So number one, there is no contraindication to giving it to a breastfeeding mother. Number two, pediatric vaccines are not yet available. So until then, we will have to, this is called passive immunity. Until we are able to achieve active immunity by vaccinating, we will have to not only do this, we will also have to follow everything else, including keeping distance, wearing mask, and teaching hand washing. So we cannot emphasize that enough.
Correct. Shall I go on to the next slide?
Sure. Yes, please. Yeah.
Yeah, so these are questions that I actually sent to you based on hearsay, from the newspapers, from the media, that there was a news item saying vaccines have a microchip that is used to track the population. Vaccines have, I had one of my friends saying that why should I take a vaccine which is a genetically modified organism?
Mm.
And, I have another friend who was reluctant to take the vaccine for a long time, who because she believed that herd immunity is better and we should wait for herd immunity. So there are a lot of misconception about vaccines. So I would like
Sure.
you to deal with them.
Yeah. Yeah. So I think I'll start with the first three because I did send you some, data for the next three. So the first one, the microchip, very interestingly. So one is uh, there is no microchip. Number one. Number two, nobody needs a microchip to track you. You have a phone.
Yeah. Yes,
You are
you are very
you are
right.
easily you know, you are easily trackable based on your phone. So
Total.
there's no yeah, so there's no reason to put a microchip into a vaccine. The genetically modified organisms, so it's actually these are, what do you call it, a lot of these vaccines are what's called an adenovirus. They are proven to be non-harmful, and what they do is they carry, shall we say, instruction for manufacturing antibodies. And it actually, where it does manufacture it is, it manufactures it within the cell. It does not, so it goes in, it makes your body manufacture antibodies against it. So what it's doing is, it's like introducing a foreign body and your body automatically decides, I need to do something to get rid of it. So you are manufacturing the protein which cannot infect you, and your body automatically responds by making antibodies. None of these organisms can alter your own DNA because it doesn't enter the nucleus of your cell, and you are not going to be some sort of mutant at the end of the vaccine. The
Yes.
last one, herd immunity, I think I've heard a lot of people talk about herd immunity. And I think people talked about it because at that point in time, there were no vaccines available. So what people have calculated is that to achieve herd immunity, so when you say herd immunity, what we are saying is enough people in the population have the disease so that the virus cannot survive by infecting more and more people. We started with saying at least 70% of the population needs to have. Now, with the more transmissible variants, we are saying we need about 80 to 90% of the population to be infected or to have antibodies against the virus so that the virus just gives up. Unfortunately, one of the things that this virus does, the antibodies it makes after infection are not long lasting. So last year during the first wave, people actually looked to see, and they found that antibody levels in Mumbai, in the slums, were close to 40 to 50%. So if these antibodies were long lasting, by the time the second wave came around, almost everyone should have been protected. And then this year again, studies to look at antibody prevalence have been done, and they found that these have not gone up. Most of the metros are still have only about 20 to 25% antibody seroprevalence, similar to the first wave. So it looks like herd immunity is not. You are never going to be have enough antibodies persisting in the population for long enough to get rid of the virus. And then the second thing is, although children don't have that much of mortality, all of us have seen these horrific pictures of, uh, crematoriums overflowing. So by the time you achieve herd immunity, you are going to wipe out a significant amount of the population. So that's not the case in adults, but as I mean, not the case in children, but as adults, we need to look out for ourselves also. So I would say vaccination is the way to go. Okay, move on to the next three, Visu.
Yeah. The side effects of vaccine. A lot of people, even yesterday, one of my friends messaged me, Dada, I have a date for vaccination today. Should I go ahead and do it? I'm scared." So he was scared about side effects. And at night, 11 o'clock, I received a message from him saying, "Dada, I have high fever. I'm not doing well." So these kind of misconceptions are there in people. There might be fever. So what?
Exactly.
You,
So
you can.
every vaccine, yeah, no, absolutely, no, go on, go on, go on, go on.
No, I'm done. I'm done. I
Yeah,
just want.
so every vaccine has minor side effects, and these are, we expect these side effects because what you're doing is you are giving something foreign, your immune system is reacting to it. So, fever is probably one of the commonest side effects, but some of the reasons that people have brought up for not taking the vaccine, the first one, this vaccine causes infertility. This is a very common
Yeah.
misconception. And this has been found with a lot of vaccines. I think at some point in time, even polio vaccine faced this problem because a lot of people said, we don't trust the government. This vaccine is given not to cure polio, it's actually to make us infertile to reduce the number of children we have.
Okay.
And this is very interesting because these stories have been heard during the polio eradication program. These stories have been heard even from places like Africa, Nigeria especially. So there is definitely no evidence that the vaccine causes infertility. Then the second one was, that's why they are not giving it in pregnant women because it causes miscarriage. Again, that's not actually the reason. The reason it's not given in pregnant women is because pregnant women and children are considered a vulnerable population. Pregnant women, because you have two lives, responsible if you are going to take a vaccine. Children, because you can't, they are smaller, they may not react the same way as adults. So always adult vaccine trials precede pregnant women vaccines. And interestingly enough, now over 100,000 pregnant women have taken the vaccine in the US. They received Pfizer vaccine, and there again, most of them were healthcare workers. They were not part of a trial. They just walked up and said, we are frontline workers, we are healthcare workers, we want the vaccine. So they had to sign a waiver saying that, if anything happens, it's your responsibility. Over 100,000 women have taken the vaccine.
That's a
Pregnant
large
women.
number. That's a
Oh,
very
sorry.
large number. That's a
Very
very
large
large.
number.
Yeah.
Very large number. So, in the UK, pregnant women are currently being vaccinated, but these are still with the Pfizer and Moderna vaccines. So, in the UK, once data comes from the AstraZeneca, which is our own Covishield, which is also being given there, once that data from pregnant women comes, I am sure we'll be vaccinating pregnant women as well. Then the other one was the recovery, saying that why should I take a vaccine? I have a 99.97% chance of recovering, but a 3% chance of getting major side effects. So that was one of the things that I put up on the next slide. We'll go to the next slide. I'll just tell you the second question was, if you had COVID, you don't need the vaccine. And the third question was, if there are new strains, oh, this vaccine is not going to work. So shall we just go on to the next slide?
Yeah.
So this is just to compare the side effects with ordinary DPT, the triple vaccine, and Covishield. I know we spoke about this in one of our previous ones. If you look at that, fever is seen in 47% of DPT and only 24% of Covishield.
Correct.
DPT even has been documented to cause drowsiness and local reactions such as swelling at the injection site. That is seen in both Covishield and DPT. And the other things that you can get with Covishield are myalgia and headache, but none of these are considered serious side effects. So these are things to be expected when you take a vaccine. And I think, Dr. Biswas, you are making this comment last time that when all of us were dragged to the vaccine clinic by our mothers, nobody said, oh, this child, the vaccine is going to cause fever, so I will not take vaccine. It was more like, if this is good for you, you better take the vaccine. So,
Correct.
unfortunately, you can't do that with adults. Now,
Yes.
serious side effects have been documented, and this can be anaphylaxis or serious adverse reactions. So, what is the risk of that? I think one of the questions was, oh, it can be seen in 3 out of 100. So, why should I worry? Why should I take the vaccine? The actual incidence is 0.0001%, which is actually 1 in a million or 1 in 10 lakhs.
Okay.
And the thing is, if you go to a reputed vaccine center, there is an
Uh,
observation period of 30 minutes.
yes.
There is always a nurse with resuscitation equipment. So one of the things we were saying is, if you're taking a vaccine, please stay for half an hour. Make sure that and it's a good vaccine center where it's not terribly crowded. There are actual medical personnel giving the vaccines.
Correct.
Despite all these precautions, your risk is only 1 in 10 lakhs. So using serious adverse event incidents as a reason to not take the vaccine makes no sense. Can I have the next slide? Because this is actually a comparison. This is a slide which Dr. Olinda sent us. Olinda is our classmate in Bangalore. And this is from the UK, which actually shows on the left the number of ICU admissions in older people per 100,000. So the blue dots, less ICU admissions in younger people, all the way down to close to 95 in those over 50, and over 100 per 100,000, which means almost 1 in every 1,000 person over the age of 60 with COVID infection is going to need hospital ICU admission. Now you compare that with the incidence on the right side, which is the orange colored dots. For the same 100,000, the risk at the very maximum is going to be 0.2. So, for whenever you take a vaccine, there's always a comparison. There's always a risk benefit ratio that you look at. We know there can be serious side effects, but that is 1 in 100,000 to 1 in 100,000, 1 in 10 lakhs. Compare that with the benefit of the vaccine. And, so there is no question that the vaccine, you do need to take the vaccine, especially if you're, in the older age group like us.
Mhm.
Sure.
Thanks. Great. Next slide.
Yeah, and the next slide is actually one of the questions saying, if I have had the infection, should I take the vaccine? So remember I said, if you've had the infection, your vaccine duration is short-lived. Uh, so it does not last beyond 3 to 6 months. So the vaccines that you get are not going to protect you beyond that period of natural infection. The antibodies you get after natural infection do not protect you beyond that period of time. So this is a very interesting slide. This is actually looking at antibody levels. I'll take you to the left lowermost, on the left side. Yeah, that is the antibody level pre-vaccine in some, and then the blue dots on the right side. Dr. Biswas will go to the orange dots. So if you're uninfected and you take the vaccine, that is the amount of antibody you get. Now you move on to the right side, the blue dots there. Those are the antibodies you get after infection within the first 2 to 3 months. And so one benefit of taking a vaccine during that period of time is, if you've taken your first dose of vaccine after your infection, is that your antibodies go up by nearly 100-fold. So there may be no advantage to getting the infection, but there's definitely an advantage to taking a vaccine after you've had an infection. The antibodies after infection don't protect you. Vaccination after an infection actually boosts your antibodies. The next
Correct.
slide.
Yeah, so we have
Yeah,
covered a question based on this in a
sure.
previous discussion. I'll just pose
Yeah,
the question once again for the benefit of our viewers.
yeah.
So, how much time should a person wait after having had COVID infection before he or she can go ahead with the vaccination dose?
Normally, what the government now says is 3 months. So anywhere between 2 to 3 months after the infection is the ideal time. The 3 months is based on the fact that you have adequate amount of antibodies to protect you for about that period of time. So I would probably take it at about 2 months after the infection. That would probably be a good time to take it.
Earlier, I remember having read somewhere that one can go ahead with the vaccine say as early as 2 weeks after a COVID infection. Does that hold good now, or we should wait for 2 months?
So the fact is, we don't really know, you know. So going by just this data here, I would say you can take it at any point in time. But we are sort of sure that antibodies are persistent for definitely for 2 months after the infection. I mean, that
Okay,
is a given. So my lodge, I mean, my advice would be rather than waiting for 3 months, take it somewhere between 1 to 2 months after the infection.
sure.
And the advantage being that that one dose of vaccine will actually boost your antibodies. You don't even have to wait for 2 months. Even a month after the infection is good enough.
Okay.
Sure.
This is the next slide. The efficacy
Yes.
of
So
single dose
single
vaccine.
dose. Yeah. So this was actually that last question, which actually said, there are many variants going around. Is the vaccine going to be efficacious? So this is actually vaccine. This is data from Scotland, where they vaccinated between, and you can see at the bottom, the first dotted line, vertical line, the vertical line near December. Yeah, so December after the first week is when they started vaccinating their population. They started with the older age group, and they continued vaccination. The next two dotted lines are actually the period of which they had a lockdown. They vaccinated over 1 million people during this period of time. And the wavy lines that you see there, the red, black, and blue, these are the age groups. These are the hospital admissions. It took about a month for the numbers to start falling. So December is interesting because December is the time when the first variant, the alpha variant in the UK, was spreading. So they had actually much higher numbers during that time. The effect of the vaccine started kicking in about a month after vaccinating, because your vaccine antibodies uh, start becoming evident between 2 to 4 weeks after the vaccine. So by the time the middle of January was over, what was seen is infection started coming down. And this was with just one dose of vaccine, because at that point the UK and Scotland were following a policy of, let's just give everyone one dose of vaccine and see what happens. So even that single dose of vaccine, and what you must realize is the same thing we are talking about. They were not doing antibody levels before vaccinating. If you had an infection, if you had an asymptomatic infection, nobody knew, you just walked in, took a vaccine, and then they compared that with their unvaccinated population. And what they found is that they were also giving the AstraZeneca vaccine. They had an 88% protection against hospital admission with just the single dose. Now, that is the alpha variant. We know that this alpha variant was prevalent in January. It has now been replaced by the delta variant, which we are hearing so much about. So, the next slide. Now, one of the questions that's raised is, okay, the vaccine may not work well against the newer variant. So, this just came up on was put up by Public Health England just today. This is the effectiveness of the currently available vaccines against the Delta variant. The Delta variant is actually responsible for about 80% of infections and the second wave in India. 80% of UP samples, 80% of Gujarat samples, over 70% of Gujarat, over 70% of Puducherry samples, and more than 50% of most of the other states is due to this particular Delta variant. So the vaccine effectiveness with the AstraZeneca or the Covishield vaccine against, this is that box I put on top, symptomatic disease, was 67% against symptomatic disease with the Covishield, which means you are likely to have symptoms in about one third of people exposed to the infection. And then when you looked at the same population, and this is in about 13,000 vaccinated people, what was evident is that the AstraZeneca, which is down the box at the very bottom, uh, the first one is against the alpha, the second is against the delta. So the efficacy of the AstraZeneca vaccine against hospitalization is 71% against the delta variant, and if you've received two doses, it is 92% against the delta variant. So, which means your risk of needing a hospital admission is only 8%. So, again, more reason to show that the vaccine does help even against the newer variants. Yeah, and I think that was the last slide. Thank you.
Okay. So, yeah, uh, that was a very detailed discussion on the issues of children and the pandemic and some vaccine myths. One of the points that was highlighted by your slides that is that even a single dose of vaccine gives a good amount of protection. This is important because lot of people nowadays, because the government uh, has been lengthening the interim period between the first dose and the second dose from now initially from 3 months now to 4 months. So people are worried that is it because of the non-availability of vaccine? Is it are they going to get sufficient protection? Are they going to get the second dose at all? The few friends who call me up, I do reassure them the same thing that even one dose gives you a good amount of protection. So relax. Whenever you get the second dose, that is good.
And I
Now,
think, no, sorry, go ahead.
yeah, there are a few comments in the comments box. I mean, I'd like to read them out to you. You can see them yourself.
Sure.
I mean, if you're going saying something, go ahead.
No. What I was saying is the reason initially for lengthening the vaccine, the duration between vaccine doses, was actually based on AstraZeneca data from the trials, which showed that you had a better antibody response if you increase the gap between vaccines. But I
Correct.
think with the newer, more transmissible variants, I think as soon as the supply comes back, I'm sure that gap is going to get smaller, because
Mhm.
as we just saw, two doses works seems to work better. But I will still not worry. I would still, if I have a single dose, I will say okay, I'm at least 70% protected, but I am not going to take off my mask, disregard social distancing. I'm still going to do whatever I can to keep myself safe.
Correct. So we have one of our friends, Dr. Sunil Datta from Melbourne in Australia, and he has put up a comment saying, "Really enjoying this really informative presentation. Thank you, Dr. Sunil Datta. Thank you for being with us. And we are soon going to have you as a speaker once again to discuss psychological issues of children." There is a
Good.
viewer, one of my friends, Mr. Arun Gupta, who has commented the great info. Thank you, Mr. Arun Gupta, for being in the show and for being with us patiently, uh, even with that technical hitches that occurred today. We have a young friend, Mr. Vivek Gupta, who has a question. Could you please let us know about people getting infected with COVID 10 to 15 days after their first dose of vaccination? So, would you like to deal with that, Dr. Valsan?
Sure. So I think I did mention that it takes about 2 to 4 weeks for your antibodies to be fully protected. And from most of these, the data that I showed you about, protection after the first dose has all started 14 days after dose one. So I think if you are around somewhere between 10 to 14 days, you can get infected, number one. Number two, remember when we said vaccine efficacy, the definition of vaccine efficacy is disease in the, when you say 70% vaccine efficacy, what it translates to in real terms is 70% less disease in the protected compared to the unprotected. So, which means 30% can still have an infection. It's not 100%. There are very few vaccines that are 100% protected. But where all these vaccines are useful is actually because they bring down the severity of illness. So I think that, and we saw that with the Delta variant, your risk of hospitalization was only 8%. 92% were protected against hospitalization, and 67% or about two-thirds were protected against, shall we say, infection. So it's not unusual to have an infection 10 to 14 days after a vaccine. The severity of the illness is often less, and so I mean, what I'm saying is, it's not uncommon. But
Yeah.
I think what we all take heart in is the fact that you are more likely to have a mild illness rather than a severe illness, unless you have other underlying comorbidities. So I mean,
There
was there
are
anything else you wanted to say, Bisa?
There are two comments which come to my mind, Dr. Valsan. One is about the incident of the Pakistan Prime Minister getting COVID a
Yeah,
day after vaccination. So
I know.
obviously he must have had the disease within him a few days ahead. And number two is that we all have received measles vaccination in our childhood, right?
Yeah,
Uh, Now, you as a pediatrician can answer this. I probably know a little bit that children can get measles even after vaccination. Is that right?
absolutely. In
Yes.
fact, it's very interesting because measles vaccine in the West is given at 12 years of age. Sorry, at 12 months, after 12 months of age, at 1 year of age. So
Okay.
at that point, it's close to 95, 96% protected. Um, Now, when Dr. Jacob John was, part of the national group for immunization advice, what the government of India said is, well, we can give it at 12 months, but all our children will get measles by then. Measles was a disease that was prevalent between 6 months to 12 months of age, more between around the age of 9 months. So then that is why we give our first dose of measles vaccine at 9 months. But giving it at that point actually brings down your protection to only about 70%. You're still at risk of attenuated or less severe measles.
Yeah.
So you can still have measles. So there are many factors, but the interesting thing is there are very few vaccines that are 100% protected. Even chickenpox vaccine is not 100% protected. Varicella or chickenpox infection itself is 100% protective. Vaccine is less protective, but if you are an adult and you've never had chickenpox, you'd rather have the vaccine than have chickenpox at this stage in life.
Correct. So I just wanted that point to be highlighted that there is no
Sure.
vaccine which can give 100% protection against anything. Well, we have had a very detailed and lengthy discussion. Thank you, Dr. Valsan, and many thanks. And our viewers really enjoy listening to you. That's the feedback I have received from our staff and many of our patients who listen to this show. So we will have you back again on some relevant topic or the other.
Thank you very much for having me. As always, I enjoy these sessions, and I have to figure out how not to have these technical issues the next time. Thank you very much.
Okay. Bye bye. Thank you very much.